Good morning. Thank you all for being here. You guys are the warriors that made it to the last day, and I'm honored to be on such an esteemed panel, so thank you, moderators. Like you said, my name is Kristen Wong from the University of Alabama in Birmingham, and I've been tasked today to talk to you about endoscopic anti-reflux procedures, specifically anti-reflux mucosectomy and anti-reflux mucosal ablation. I have no disclosures. So when thinking about solutions to reconstruction of anti-reflux barriers, in the United States right now, endoscopic approaches include targeting only the lower esophageal sphincter and the sling fibers. We're not yet able to target the hiatal closure endoscopically. The role of endoscopic procedures remains undefined due to limited long-term data and comparative data. No consensus exists currently on how to use these procedures, and you're not going to find them in any current clinical guidelines. But as the group of procedure evolves, it's proving to be serving as an alternative to anti-reflux surgery, or even touted as a bridge therapy between pharmacologic treatment and surgery. So endoscopic approaches should be considered in PPI non-responders or those who are dependent, in patients who have contraindications to PPIs or who are having concerns regarding the long-term effects of those PPIs, or those who don't qualify for surgery or for some reason refuse it. The ideal candidate should not have a hiatal hernia bigger than 2 centimeters, should not have severe erosive esophagitis, should not have a significant esophageal motility disorder, or ideally shouldn't have had any prior interventions at the GE junction. Many promising endoscopic therapies have disappeared because of low efficacy or unacceptable adverse effects. Those shown in red here are no longer available because of those reasons. Ideally, an endoscopic anti-reflux procedure should demonstrate non-inferiority to surgery alongside a shorter operation time, lower complication rate, and lower secondary long-term morbidity. And finally, they should not preclude a future fundoplication in case of failure. This is a good quick shot of the endoscopic approaches that are being done currently in the U.S. I'm going to focus on the newer procedures of anti-reflux mucosectomy and anti-reflux mucosal ablations. And these procedures, as you will see, have the advantage of being able to use standard endoscopic equipment, which means that they're less costly. And from a technical standpoint, they are fairly easy compared to the other endoscopic approaches. So for ARMS and ARMA, you'll want to do the same preoperative workup as you would for your anti-reflux surgery patients. Endoscopy looking for esophagitis, masses, strictures, ulcers, etc. An esophagram looking for a hiatal hernia. pH testing is necessary right now to get a pre-op baseline, and we don't have much literature on this, so it will be helpful to contribute. And high-resolution manometry to rule out any significant esophageal dysmotility disorders. So I'm going to take you through quickly the 3 quick steps of an anti-reflux mucosectomy. I want to note that the first case was reported by Inoue in 2003 when he did an EMR for high-grade dysplastic Barrett's of the GE junction and found that that patient had resolution of their reflux symptoms up to 10 years after that procedure. And then his group went on to publish the first pilot study in 2014 showing good symptom improvement. So your goal here is to rebuild the flap by scarring in a superficial ulcer created by performing the mucosectomy. So here you'll see us doing the submucosal lift with a mixture of methylene blue and saline. We're doing this through a single channel scope. What you're doing here is creating a pseudo polyp. And then you go back in with the over-the-scope banding, the same banding application you would use for hemorrhoids. You're sucking the mucosa into the cap and banding it to create the pseudo polyp. And then fast forwarding here, we're going to go back in with a hot snare, and you're going to loop the pseudo polyp underneath the band and ligate it. And the defect that you're going to create is shown right here in the mucosa. And then you're going to repeat this circumferentially for about 270 degrees, sparing the greater curvature side in order to augment the angle of His. This is showing a pre-op picture top left, intra-op picture top right, and then progression at 1 to 2 months. And you can see that scarring is creating a closer hug of the scope. So what data do we have on this? Well, other than Inoue's group, Mike Ujiki published the first case series in the United States in 2019, a case report of 19 patients. 2/3 of patients reported improvement in GERD-related symptoms, which is pretty consistent with what the Japanese literature has found. Dysphagia occurred in 3 out of those 19 patients, and that was due from stricturing of the LES after scarring. These were treated mostly with dilations, and 1/3 of these patients failed to improve their GERD symptoms, and half of those went on to have anti-reflux surgery. I want to mention a meta-analysis also from 2022, not shown here, but they totaled 307 patients worldwide from 10 studies. The technical success rate of ARMS was about 98%, and clinical success was touted at 80%. The most common adverse effect is dysphagia and lower esophageal sphincter stricturing at about 11%. And objectively, GERD HRQL is improved by about 15 points, and they did do some objective testing afterwards, and acid exposure time improved by 2.39 points. We're also starting to get literature like this. This is a newer study out of China showing that anti-reflux mucosectomy also can improve LPR symptoms. So switching gears a little bit to the anti-reflux mucosal ablation. Same idea here, but instead of resecting the mucosal layer to create scarring, you're burning it with an argon plasma coagulation catheter. So ulceration is created either in a butterfly configuration or a hemicircumferential. You're doing the width of about 2 centimeters of burn, and you're leaving a 1 centimeter area of mucosa between the scope and the ulceration. Technically, this is much easier and with the theoretical same effect as performing the mucosectomy by EMR or ESD. Inoue's group published their pilot study on this in 2020, total of 12 patients followed up for about a year. The median GERD HRQL score improved significantly from 30 to 12. Median Demeester score went from 33 to 2.8 on an average. And there's also an improvement in acid exposure time, as you can see. And this is very recent data from January of 2024. Inoue followed up with a 2 large institution study. Clinical success rates at 1 year post-ARMA were 70%. GERD HRQL improved from 26 to 11. Acid exposure time went from 5 to less than 1, and 13% of these patients required balloon dilation. There were no serious events, including no perforations. The important thing about ARMA that is different than ARMS, besides being technically easier, is that this is repeatable. So whereas ARMS is difficult in a redo field to get that submucosal lift, this can be repeated and has been shown to be successful over and over again in 60 to 80% of patients. So here's a summary of published data as of 2021, all case series, no randomized control trials, clinical success rates ranging from 50 to 100%, but mostly in the 60 to 70% range. And they do have acceptable adverse effect rates, as I keep mentioning, the most common being dysphagia with stricture requiring dilation. And I show you this just because people are trying to do now different iterations of this. This is a anti-reflux mucoplasty where they're resecting the mucosa, and then they're zipping it back up with either clips or suture. So in conclusion, endoscopic approaches are relatively safe with low side effect profile. Do they successfully bridge the gap? I think ARMS and ARMA techniques certainly fit into an algorithm better for treating GERD than techniques like endoscopic plicating because it doesn't make any future surgeries difficult. There are certainly not replacements for anti-reflux surgery, though. And finally, in limited case series, ARMS and ARMA seem to be successful in symptom improvement in roughly 2/3 of patients, and early studies show that they do decrease pathologic reflux. Thank you.